So you want to make advanced preparations for the parents. And what I mean by that, talk to them like, let's go and see your baby today, maybe in an hour, so that we can get them ready and I can let the nurses know that they're coming and that this is their first visit. You want to assist them and support them during the initial visit. And this is, if you look in this environment and try to put yourself in your parents' shoes from a parental perspective, and stop thinking about what you are looking at from a nursing perspective, you can see how intimidating this view might look to a parent and why it may be really hard for them to process all of these different devices, all of these different sounds, all of the things that are hooked up to their baby. So one of the things that you can start with doing is giving very simple explanations of their environment. We have the baby under this machine to help keep them warm, or we have this machine that's hooked up to monitor the baby's breathing, so that they can kind of understand what all of this entails. We know, but for them it's a very intimidating kind of environment, and they didn't expect to be placed in this situation. You want to provide information, institute skin-to-skin care, or it's also known as kangaroo care. We try to facilitate interactions and increasing their ability to make decisions about their child. We want them to be able to have their concerns alleviated. So if there's something that they're worried about or concerned about, I want them to talk to me as the nurse so that we can try to help alleviate their concerns. If it's not me, maybe I can get the other person who they need to speak with to try to alleviate what may be concerning them. You want to help them with ongoing problems, and always from day one we start preparing them for discharge. We're going to move to some of the other common complications of the preterm baby and specific to preterm infants. Now, I talked about respiratory issues, but now we're in the complications. So now we're going to talk specifically about respiratory distress syndrome. And this condition is primarily caused in the preterm baby with the baby not having enough surfactant at birth, which results in atelectasis, the alveoli collapse, and they cause the lungs to collapse. So the baby will have low SpO2s and low concentrations of oxygen in their blood. The primary cause is this insufficient production of surfactant, which is that soapy phospholipid that lines the alveoli, and we talked about that in the normal newborn. It is first started to be produced in utero at about 22 weeks of gestation. However, it's not in adequate amounts to support the lungs outside of the uterus. By the time the baby reaches 34 to 36 weeks of gestation, production of surfactant is mature enough to support breathing outside the uterus, and the baby can typically breathe on its own. Surfactant really decreases the surface tension that allows the alveoli to remain open when they breathe air in, and it has to be continuously produced. If they have too little surfactant, the lungs become stiff and they become non-compliant. They don't expand well, the alveoli will collapse, and the baby will develop atelectasis, acidosis, and necrosis of the lungs. So the key to understanding the amount of surfactant production we talked about is their lethogen-sphygmolin ratio, and we do assess this for babies that we're worried about may not reach term in gestation. So they'll detect it by pulling off some amniotic fluid to look at the baby's LS ratio and help us determine the fetal lung maturity. Some of the predisposing factors to developing this condition, obviously preterm birth, we talked about that, but C-section without labor, if mom had diabetes, if you had an acute antepartum hemorrhage, mom was bleeding, baby's in utero, if this is the second of twins that are born, if the baby experienced some type of asphyxia at birth, if the baby has a lethogen-sphygmolin ratio of less than 2 to 1, can all increase their risk. Now, the respiratory distress syndrome results in because the lungs are immature, they don't have enough surfactant, they'll have poor gas exchange, and they may need to be put on a vent. You see this primarily in preterm babies, but in some cases we can see the development of respiratory distress syndrome in babies that are born to moms who've had C-section without labor, or babies that are born to moms who have diabetes. So they're going to do a chest x-ray on this baby, and they're going to notice this ground glass appearance on the chest x-ray that has to do with the collapse of the alveoli. In addition, the symptoms that you're going to see, again, tachypnea, grunting, flaring, retractions, cyanosis. They can have, tachycardia, and in some instances, because they're born early, they don't have the closure of all those bypasses, so they may have a cardiac murmur. What are we going to do with these babies? So we talked about general respiratory support and the issues under the normal preterm baby. Now we're talking specifically to babies who have respiratory distress syndrome. We obviously are going to maintain thermoregulation. We need to maintain adequate oxygenation, so we may put them on some type of device to assist them with oxygenation, whether it be CPAP, or maybe they need to be on a ventilator. We can do those things. We're going to try to maintain their blood pressure. Babies can also benefit for what's called surfactant replacement therapy, or rescue surfactant therapy, which is where we give surfactant after delivery down the ET tube. And actually some babies do quite well with that. We're going to have a close assessment and monitor their fluid and electrolyte intake, their nutritional intake, and they usually will give them a broad spectrum antibiotic to try to prevent them from developing a respiratory infection on top of the respiratory distress syndrome. Babies can develop a condition called bronchopulmonary dysplasia. This typically affects your really early preterm babies, babies who are on a ventilator for a long period of time. It's a chronic lung disorder that develops in babies who need extensive oxygen therapy or ventilator support. And basically what happens is the lungs become scarred, they lose their elasticity, and it's due to being on the vent for a long period of time. It does occur in as many as 40% of babies who are born weighing less than 1,500 grams, but there have been some positive interventions that have decreased the severity of the babies developing bronchopulmonary dysplasia, because what used to happen is these babies would ultimately become vent dependent for life. In many instances, we couldn't get them off the ventilator, so they would go home on a vent and would be on a vent for the rest of their days. But we now have included using not just rescue surfactant therapy, but also treating them with certain types of steroids. And between the rescue surfactant therapy, the steroidal therapy, and some of the other respiratory interventions that we put into place, these babies may not be vent dependent for life. They may have respiratory issues, but they may not always have to be on a ventilator. Again, this is going to be a case-by-case approach, but what you're going to see more current in our approach to what used to be is we're going to put them on the vent as long as we think we need to, but we're going to try to wean them off quickly so that they're not on those high pressures of O2 and ventilation, mechanical ventilation, for long periods of time. When you look at the pathogenesis of respiratory distress syndrome, a couple things I want to point out to you so you can understand what I mean when I say it's not just surfactant, it's also the alveoli. What I'm showing you is the differences in the alveoli based on weeks of gestation. And when you look at the babies from 16 to 26 weeks in gestation to a baby who's 36 to 41 weeks in gestation, there is a lot of development of their lungs, even from 24 to 34 weeks versus the 36 weeker. Just in those few weeks, there's significant development of the alveoli in their lung structure. So if they're born early, not only do they not have enough surfactant, The alveoli are immature, as I was showing you in earlier pictures when we were talking about the respiratory needs. The alveoli are not mature. They're weaker, they're not as well developed, and they don't have as direct contact with the blood vessels as a term baby's alveoli would have. So when you're looking at bronchopulmonary dysplasia, again, it's caused by the effects of oxygen delivered over time at increased pressures or at high pressures. And it causes the epithelial tissues of the bronchi and the alveoli and the lungs to be scarred, become scarred and necrotic. And so they will continue to need oxygen and sometimes the ventilator for greater than 28 days of life. This is going to be supportive therapy. We're going to try to wean them off of the vents as soon as we can, but they're also going to receive, in addition to steroids, diuretics, and antibiotics, they're going to receive some respiratory support. And you're going to see respiratory therapists coming and working with these babies. Research has shown, and it is that some babies can develop new alveoli, and they can have alveoli development that can continue. If they show significant improvement within the first 2 years of life, that's good. They may not be vent dependent for life, and the respiratory issues that they may have had may go away over time. But if they don't show improvement within 2 years, they may continue to have respiratory issues for life. The next high-risk condition I want to talk to you about is periventricular or intraventricular hemorrhage, and this is a condition in the brain that primarily preterm babies have, and it has to do with the fragility and the immaturity of the blood vessels in the brain, specifically in the matrix around the ventricles of the brain, and it's on a grading system, grades 1 through 4. So basically these tiny little fragile red blood vessels in the baby's brain, the preterm baby, ruptures, and depending on how much bleeding and where the bleeding is, and the severity of the bleeding can tell you a great deal about the outlook for this kid. So a grade 1 is a small amount of bleeding in the brain. A grade 2, the hemorrhage extends to at least one of the ventricles. A grade 3, the bleeding distends at least one ventricle. And a grade 4, they have significant bleeding in their brain. Grades 3 and grades 4, you more than likely is going to have some type of neurological abnormalities with this baby. And a grade 4 bleed, they may not survive. I have seen, however, some babies do quite well that have developed a grade 3 or bleeding in the brain, but that's not every kid. This is in general, and this is kind of what I want you to think about. Grade 1 and grade 2, they usually do okay, but grade 3, grade 4, you're looking at some possible neurological issue. In grade 4, they may not survive. So when you look at this intracranial hemorrhage that originates around the matrix of the brain, you can have, there's a couple things to take in consideration. They can have early intraventricular hemorrhage, that's bleeding that develops within 72 hours of birth, or late intraventricular hemorrhage that develops after 72 hours of life. This bleeding is destructive to the developing baby's brain and can cause significant injury and neurological insult. And what you're seeing in this picture is a baby who has a periventricular bleed in the brain, and you can see in these areas where a ventricle has been distended. And this is on autopsy. This would be a grade 4 bleed. You can see that this baby had extensive bleeding in the brain due to the ruptured blood vessels. When you look at the signs and symptoms of intraventricular and periventricular hemorrhage, at first there may not be any signs, but you might see symptoms of, if they do develop bulging fontanelle, signs of increased intracranial pressure. The things that we're going to do for this baby, we're going to try to keep the cerebral blood flow constant. So they're going to try to keep the baby's, the head of the bed elevated. We're going to do things to try to prevent increase in the baby's blood pressure and try try to prevent a drop in the concentration of blood in their the concentration of oxygen in their blood.